Okey, kita mulakan kelas untuk OCT 530 ni. Untuk lecture yang kedua, bertajuk Role of OT in Management of Client with Psychosocial Dysfunction. Okay, this is we're going to discuss more on the role of OT, how we manage this patient. So as you all know, in terms of management, we're going to discuss role of OT in management of client. And at the same time, we're going to discuss theoretical models and frame of reference in psychosocial rehab and a bit of evidence-based studies regarding our intervention. So as an OT, we believe and we value occupation. This is the thing that we are for. That's why our profession is known as occupational therapy, because we value occupation. At the beginning, we known as moral treatment philosophy. At the beginning, we've been known as our intervention known as moral treatment philosophy, because it includes respect of human individuality and the belief that a human approach using daily routine and occupation could lead to recovery. So as an OT, we have to believe this thing, that when we use daily routine and occupation, it could lead to recovery. So whatever you design your intervention must involve daily routine and occupation. That's why when this MCO been imposed for Malaysian citizen, when you all experience MCO, what are the things that affected? It will affect your routine, kan? Daily routine as a student. Apa daily routine of student? Daily routine of student, you have to go to lecture room, class, you have to go to lab, you have discussion in group, and then you have a leisure between you all. If the thing being cut down or being imposed of MCO, hormone control order, so affect your daily routine. So at the end, what is going to happen to you? If you didn't balance your lifestyle, if you don't have any coping skill to cope with this MCO issue, so it can lead to some of you can get depression. It's not it's a real thing. During MCO, also I've been called by parents. Some of you all ada depression. So how about you all? Ada tak pengalaman? Ada tak pengalaman you stress, macam depressed, macam lost? Ada tak? You all dengar ke tidak ni?
Ada. Ada.
So you seems like you lost, kan? Sebab you tak boleh buat apa-apa you punya rutin harian. But because of probably you punya mechanism bagus to handle this situation. tak adalah terjejas stroke. But some of you, parents being called me, dia punya anak seems talk by himself or by herself. Dia cakap sendiri dah. This is a symptom of depression. Like to be alone, don't want to talk to anyone, to the family. It can happen. As scientific knowledge and technology advance, OT defined a role for itself within the rehabilitation model. This resulted in the emergence of psychosocial dysfunction as a specialty within OT. So the trend right now is not OT in mental health, but OT in psychosocial dysfunction. Because at the end, we're going to return the patient or our client who suffered mental illness to their community, to their family. So this is what they call it psychosocial. At the end, we don't want them to live in the institution. We want to return them back to the community or family or spouse, and etc. So this is the thing that the current trend of OT in mental health, which is psychosocial, involved in psychosocial dysfunction. So when talk about occupation prescribed by OTs, is related to promotes the health and prevent and remedies dysfunction and elicits adaptation to the environment. So some of the client, our patient in mental health, they have problem in term of adapting to the environment. When talk about environment, their family, their community, their work, their neighbor, all that. So when we design intervention, we must consider at the end to adapt them to the environment. So this is what OT should be. So OT from being hospital-based, right now OT move towards rehabilitation in the community. So right now there's quite numbers in OT in health clinic, quite numbers of OT working in the community. Because it also due to our policy, our Ministry of Health policy, they want to abolish the institutions. They, as much as they can, they want to abolish the institutions. Right now, last time, when people suffer mental health, they went to Hospital Permai, Hospital Tanjung Rambutan. But right now, they want to reduce that. So every hospital, every government hospital, there is a psychiatric unit. So whenever they have issue of mental health, they refer to the psychiatric unit. And if they found that patient is at a stable condition, so they will discharge. Cases of, for example, like the institution, for example, like Permai, Tanjung Rambutan, they are all for patients who are behavioral problem. You have criminal ada criminal case, ada ganggu pada jiran dan sebagainya, then send to the hospital Permai. So right now they are in that line where they're going to reduce the institution punya treatment, intervention. So our OT service also covering not only rehab but also promotion in mental health. Some of OT working in the promotional part in Putrajaya. Some of us in mental health working in the hospital, for example, Sultan Amina, Superstar Hospital Ipoh, handle case of mental health. And some of us have been working at a health clinic. If you go to last time, there is only few numbers working in the hospital. But right now, many of us right now working at health clinic. So over there, if there is case of mental health problem, so they handle it first. They won't refer to hospital or the institutions. So as a notice, we have to respect the reality of life, real tasks of living, and the individual modes of coping with his daily tasks. So we must respect, when we do intervention, we must respect the reality of life, the real task of living, and their mood, patient mood to cope with these daily tasks. For example, your background of your client is a Chinese. Kan Chinese, dia punya culture is different from Malay, India, and then dia punya spiritual belief pun different. So we have to respect that. And their task of living also we have to respect. Some of our clients come from nelayan, from kampung, from metropolitan. Right now, daripada kalau Klang Valley ni, kalau duduk di KL dan sebagainya, dia punya living different. So we have to respect that. It has been shown that although autists value occupation, they use a wide variety of treatment techniques and approach to establish healthy habits of healthcare and psychosocial well-being. So we value occupation, but we must appreciate, we must complement our wide variety of techniques. Autis is an important and integral part of the multidisciplinary team, providing therapy service in hospital and community settings. So we cannot work alone. We have to work together with other discipline. Okay, Nur Adibah. For example, apa dia? Kalau dalam term of health professional ni yang biasa OT dalam apa OT in mental health care ni, siapa dia? Anyone? Semua tidur ke? Anyone? Yang ada dah pergi posting dah, post diploma. Siapa yang biasa work with OT in term of psychiatric care? Anyone? Nurul? Alin? Aina? Zorain? Sarah? Siapa biasa OT bekerja? Ras? Ras dah pergi posting kan? Halo?
Dah.
Siapa yang biasa OT bekerja kat hospital ni? Kat mental health ni?
Dengan psychiatrist, nurses.
Psychiatrist lagi siapa? Nurses lagi? Doktor, okey lagi? Daniel? Apa lagi? Social worker, kan? You pernah bekerja dengan social worker? Social worker ni dia understand dia punya welfare, dia punya benefit, dia punya who's the person can help the patient, social worker, and then we also other professions such as clinical psychologists, also work together. We work together with them. Selain daripada itu, attendant jangan lupa. Attendant is the main person that assist.
Hello.
Apa lagi? Apa lagi, Fik? Yang bekerja dengan OT. Takkan saya cakap je, you all pun kena cakap juga. Siapa lagi yang bekerja dengan OT? Family, dia punya spouse, wakil rakyat, kan? Ketua kampung, neighbor, all this actually we have to work with them. Industry, employer, also we have to work with them. So what is the domain of OT profession? A profession domain consists of those areas of human experience with practitioners of the profession of assistance to others. Areas of human experience, we take into account occupational therapists and occupational therapy assistant focus on assisting people to engage in their daily life activities that they find meaningful and purposeful. Or occupational therapies domain stems from the profession interest in human beings, ability to engage in everyday life activity. The broad term that occupational therapists and assistants use to capture the breadth and meaning of everyday life activity is occupation. This is by Mosley. So, our life experience, human life experience, is very important to OT. Human everyday life activities. Dia punya ability to engage in everyday life activities. This is the thing. Everyday life activity is occupation. So, when talk about everyday life activity is occupation is very vast. OT ni luas kerja dia. OT ni kerja dia luas. Bangun pagi, gosok gigi, mandi pun OT, apa dia, pakai baju, dressing, grooming, lepas tu work task, leisure, terlalu luas OT punya. But very important, the real life activity that the person experience throughout dia punya life. Janganlah dulu dia tak experience benda tu, you nak suruh dia buat, kan? Tak. So, depend on the individu or the client punya experience throughout their life. So, mental occupation is activities of everyday life, named, organized, and given value, meaning by individuals and a culture. This is by law, Polatajko, Baptist, and Townsend. I remember I met Townsend. Apa nama dia? Nama benar dia siapa? Townsend ni? Elizabeth Townsend kan? Elizabeth Townsend ni dia buat buku OT ni. I remember I met her dekat mana ni? Dekat Asia Pacific Congress, dekat Thailand. Dia, saya tengok dia pakai baju serabai je. Tapi dia one of the author of the book of OT. OT in mental health, Townsend banyak buat buku. Menulis buku. So, when talk occupation, what is it? The definition is activities of everyday life, named, organized, and given value and meaning by individuals and a culture. Occupation is everything people to do occupy themselves. including looking after themselves, enjoying life, and contributing to the social and economic fabric of their communities. So this is the definition in terms of occupation by law, Polatajko, Baptist, and Townsend in 1997. So for example, you got client, patient yang dia punya background nelayan, nelayan. Katakan dia ada depression, nelayan dia ada depression. So background dia sebagai nelayan, duduk di tepi pantai, dan rumah dia tepi pantai dan sebagainya. So as an OT, we have to recognize dia punya everyday life tu. Everyday life dia pergi ke pergi ke laut. So we have to recognize, and our treatment have to align with their everyday life. Bila balik rumah, apa culture dia, apa leisure dia. Kalau dulu dia nelayan, dia kalau orang Terengganu kan, dia suka main wow bulan. Dia buat dalam masa musim tengkujuh, apa dia buat? Dia bermain layang-layang, aktiviti leisure dia. And this is the thing that you need to visualize, kan? Visualize, analyze dia punya meaningful life of our client. So kalau you buat intervention, banyak ke arah tu lah. Seorang nelayan, dia leisure dia apa? Dia kalau aktiviti livelihood dia apa? Pergi ke laut. So you have to build up dia punya, nak kembalikan dia macam orang macam dulu, yang meaningful bagi dia. So you have to plan what are you going to do with this client by respect dia punya meaningful life and culture. So in terms of occupation, when talk about occupation, this is the context of occupation, and we want to engage the person in terms of occupation. What are the contexts that we look into? So in terms of performance in area of occupation, it can be activity of daily living, IADL, instrument of ADL, education, work, play, leisure, social participation. So this is area of performance in occupation. So whenever your intervention, you design your intervention, must include the punya performance area based on their meaningful activities, meaningful daily activities, and their culture. Dia punya culture tu, kalau dia seorang Islam, we have to align with the aktiviti solat, sembahyang, puasa, sebagainya. Kalau dia Chinese, dia mungkin agama dia Buddhis, you have to respect that. Kalau India, Hindu, dia ada dia punya religion dia dan sebagainya. We have to respect that. And there is a performance area and performance skill. Dia punya motor skill. Dia punya motor skill is about, banyak isu juga kalau patient yang suffer mental health issue ni. For example, yang skizofrenia, yang tak lama bersukan, dia ada masalah dari segi strength, dia punya endurance or motor skill, dia punya process skill, dia punya cognitive process skill, thinking dan sebagainya. Mungkin ada isu kat situ. So we have to design an intervention, and that involve process skill. Then there is a communication interaction skill. So this element is very important in terms of performance skill. Dan performance patterns. Dia punya habits, routine and rules. Habit dia apa? Habits. For example, habit dia makan apa ni? Kunyah apa dia panggil tu, orang dulu panggil apa? Kunyah apa? Apa? Bukan kunyah tembakau. Kunyah letak daun apa tu?
Daun sirih.
Daun sirih. Habit dia makan daun sirih. Kunyah daun sirih tu. Habit dia kan. Kalau dia cakap, cik buatlah aktiviti mengunyah sirih. Is a habit dia yang you kena respect. Rutin dia. Rutin ni penting kan, rutin dia. Kalau you katakan rutin harian you, bangun pagi, apa rutin harian you? Husna, apa rutin harian you pagi? Buat apa Husna? Pagi-pagi buat apa Husna?
Sarapan.
Sarapan. Pagi-pagi celik dia tu sarapan.
Tak adalah.
So
Gosok gigi dulu.
Husna bangun pukul apa biasa pagi?
Dalam suku macam tu.
Saya kalau rutin saya bangun pagi pukul 5. Kadang-kadang pukul dah bangun. Rutin saya pagi masak air panas. Apa ni rebus telur separuh, masak 2 biji, buat teh-o, ambil basuh berus gigi, mandi, lepas tu baca sikit surah-surah. Itulah rutin harian saya. Lepas tu tunggu subuh, sarapan sekejap, tunggu subuh. Lepas tu barulah mandi. So rutin harian. Dan kalau pergi kerja, rutin saya kenal Mr. Kanan, Mr. Kamal lah. Kenal lah. You punya lecturer kenal tak?
Kenal.
Rutin saya mesti berbual dengan dia. Kalau masa rehat, mesti jumpa, berbual, ketawa, musik. Kan? Ini rutin harian saya. Kalau pergi sana, kalau tak ada dia, saya sedih je. Tak ada kawan nak bercakap. Yang lain muda-muda. Kan? Yang senior berapa orang, dia berapa kerak, ada 2, 3 orang. Kalau ada pendek saya tak tahulah. Efek lah saya punya rutin. So this routine, you need to study dia punya routine. And then dia punya rules. Rules sebagai parents, sebagai husband, wife ke, rules sebagai anak. Ini penting. You know what, kalau patient yang psikiatrik ni, kalau dia punya rutin harian dia, bila dia balik rumah, kalau di institution ni rutin harian dia makan pagi tu apa? Siapa tahu? Rutin harian pesakit di Permai. Di institution. Dia makan pagi pukul 6.30 dah makan. Awal dia makan. Dan 6 petang, 6.30 petang dah makan malam. Kan? Pernah tak you pergi hospital Permai, hospital Tanjung Rambutan? Dia punya
Tak pernah.
Tak pernah. Ada yang dah pernah ni. Abang tak tahu je. Dia punya rutin.
Belum pernah.
Belum pernah. Dia punya rutin makan malam pukul 6 petang dah makan. Dan pukul lepas setengah dia dah kena tidur dah. Pukul 9 dah kena tidur. Kalau I tengok patient yang pernah I treat, dia ni nampak muka tak nampak tua. Muda-muda je. Dah lama tak jumpa ni kan. Tapi dia orang tak nampak tua. Mungkin dia orang ni tak ada stres tu. Dia orang seronok duduk sana. Tak fikir apa. Makan orang bagi. Tidur ada katil. Tak bayar bil. Tak ada tekanan. Tak payah tunggu gaji. Tak ada tanggungjawab. Dia tak makan tua. Muda je. So, patient punya habit, routine dan role, we need to taking care. Ada satu model model human of occupation. Human occupation ni recognize habit, routine and role. Very important. Bila kita tak lakukan role kita, tiba-tiba seorang si rumah dia kena stroke. Dia tak boleh lakukan role dia sebagai seorang isteri untuk memasak dan sebagainya. So really become stress. Dia become distress because dia tak boleh perform dia punya role and routine. So we need to take into account dia punya performance pattern. And then dia punya context. Context based on dia punya culture, dia punya physical, dia punya structure lah, building, dia punya bangun, duduk di mana, urban area ke, metropolitan area ke, dia punya social people around them, dia punya personal, dia punya spiritual, dia punya temporal, dia punya virtual, all these things we need to recognize dia punya occupation participation in the context of all these things. Activity demands also we need to if involve activity demand, we need to consider the objects, the property, the object use, their property, their space, their social, sequencing and timing, required action, required body function. For example, activity of grooming. So untuk wanita, kan? Activity grooming. So activity grooming melibatkan apa untuk wanita? Anyone? Untuk memakai, untuk make up, kan? Untuk sikat rambut, make up, apa lagi aktiviti? Sapu bedak, apa lagi? Lipstick, tegakkan bulu kening. So all these things, all the activity require demand, keperluan, perlukan kita punya punya function, kan? Perlukan timing untuk buat tu. Dia tak boleh lah tergesa-gesa dan sebagainya. So these activity demands, we need to consider the demands of the activity, and we also need to consider client factors in terms of body function, dia punya structures, all that, dia punya mental, all that, semua kita kena ambil kira. So OT framework, OT framework process. So the initial step is to understand dia punya occupational profile. So when you evaluate patient, the beginning, you need to understand their occupational profile. And you first, when patient see you, you need to understand dia punya history, dia punya occupational history and experience. Sejarah kerja occupation dia mana. Kalau dia sebagai nelayan, so you need to understand and evaluate dia punya experience and history. Kalau dia sebagai cikgu dan sebagainya, you need to consider that. And then their patterns of daily living, their interests, their value and needs. So daily living dia macam mana? Kalau dia kerja seorang yang breadwinner, dia ada bekerja menyara pada keluarga dan sebagainya. Dia punya interest apa dia? Kita ada punya value and needs. Sometimes kita kena tanya apa value dia and dia punya needs and dia punya priority. Apa priority dia? Kadang-kadang patient psychiatrist ni kadang dia punya priority, they want to earn money. kebanyakannya psychiatric patient ni dia nak duit. Dia pasal dia background dia datang daripada keluarga yang susah. They want earn money. Some of them they know their role as a father untuk menyara keluarga dan sebagainya. The client problem and concern about performing occupation and daily life activities are identified and the client priorities are determined. So when we evaluate patient, one very important thing is that the client priority, keutamaan dia. Keutamaan dia apa yang dia nak. When I did my plan my intervention with patient, at the end tu, I tanya dia, what is your priority? Apa yang you nak dalam kehidupan you? Kadang-kadang dia nak kembali balik ke keluarga dia. Then you have to respect this, dia priority utama dia. Utama dia nak balik ke keluarga. So, in order to go back to the family, what preparation need to do? This is the thing. You need to do dia punya do homework dia punya occupational profile. Then analyze dia punya occupational performance. So the step in evaluation process during which the client assess problem, potential problem are more specifically identified. So actual problem is often observed in context to identify what support performance, what hinders performance. Contoh patient schizophrenia, dia ni dia tak buat basic daily life. Contoh macam gosok gigi, mandi, kan? Dia tak nak buat langsung. This is the occupational performance yang kita nak tengok, kan? Kita nak dia independent in terms of dia punya ADL, kan? So you need to identify what support performance. Apa yang support dia punya nak perform tu? Apa yang hinders the performance? In context to identify what support performance and what hinders the performance. So you kena identify apa benda yang boleh support dia untuk membuat performance tersebut dan apa yang boleh hinders dia melakukan performance. So performance skills, performance pattern, context, activity demands, and client factors are all considered, but only selected aspects may be specifically assessed. Target outcomes are identified. So, at the end, what the outcome yang you nak when you design intervention with the patient. So, for example, you and the patient together with the patient, your target is, for example, they are able to independently doing their ADL, activity of daily living, or dia punya target dengan you sama, improve to independently improve dia punya IADL, sebab dia sebagai housewife, she have to play her role as a housewife untuk, for example, dia punya aktiviti memasak, membasuh baju, menjaga anak, this dia punya outcome yang dia nak. So you have to plan apa performance yang dapat support dia punya performance tu. Apa yang boleh hinders dia punya performance tu. And then you have to come up with intervention plan, a plan that will guide action taken that is developed in collaboration with the client. So you can ada plan, you can collaborate with the client. It is based on selected theories, frame of reference, and evidence. So outcome to be targeted are confirmed. So when you have discussed with the patient, this is the priority and the needs, and this is what they want. So you have to find, you have to plan your intervention based on theories, frame of reference, and with the evidence. So there is evidence. There is evidence. For example, your target outcome to they want to kembali bekerja. They want to do work. So there is evidence when patient is stable, they terus hantar bekerja. Tak perlu lalui intervention of dekat OT department, prepare dia punya habit of working dan sebagainya. Sebab ada evidence yang mengatakan kalau patient dah stable, terus hantar balik dia kerja. So whatever we do must be based on theories, frame of reference, and evidence. Then next step is intervention or implementation. We have to implement our intervention. So ongoing action taken to influence and support improve client performance. Intervention are directed at identified outcomes. Client response is monitored and documented. So whatever you design your intervention, you must ongoing taking action to influence and support to improve the client performance. So intervention are directed at identified outcomes. So your intervention must be ongoing support being given to them, and it must be monitored and documented. So whatever you implement your intervention must be support to improve the client performance. So then outcomes. The last one, outcomes, is the determination of success in reaching desired targeted outcome. So outcome assessment information is used to plan future action with the client and to evaluate the service program. So the outcome determine of success in reaching desired target. So the outcome is whether you success in reaching desired targeted outcome. So it's very important. Kalau katakan you punya outcome is for them to work independently at certain place, katakan. Dulu I buat intervention dengan patient ni. So I target outcome dia ni, dia boleh bekerja selama sebulan. Okay, this is my target outcome. Sebulan, dia cuti, katakan kalau dia nak mohon cuti, cuti dalam seminggu sekali. This is my target outcome. And dia kerja pun, ada kerja, ada gaji. So bila I dah capai target outcome tu, I review balik. So my target, the next target is to them to permanent work. Dah tak ada gaji hari, jadi permanent work. So I discuss dengan employer, 3 bulan pertama ni kita nak tengok dia boleh bekerja tak sendiri, and then dia boleh balik sendiri tak dekat hospital. Sebelum tu kita ambil dia, hantar by van ke ambulans ke. Next, by target dalam 3 bulan ni dia naik bas sendiri. Dia cuti tak banyak dia ambil, dia boleh kerja sepenuh masa, gaji tetap. So you must have target. Then if you reach your target, you have to review balik what the plan for future action with the client. So ada soalan tentang OT proses ni? OT framework process? Anyone? Ada soalan? Sarah?
Tak.
Ada. Firdaus? Ada soalan Firdaus? Rashida? Nurul? Yasmin?
Tidak.
Semua okey Jangan tidur semua Jangan lari. Okay. Then this is the framework of collaborative process model. So when you want, this is the framework collaborative process model. So in terms of context, so this is dia punya occupational profile. You analyze dia punya occupational performance. You evaluate. This is evaluate. This is a collaborative process with the client. You as an OT, you need to collaborate with the client, discuss what are the outcome they want. Then you also have to discuss what are your intervention. So in terms of the context, dia punya cultural, dia punya physical, dia punya spiritual, in terms of the context, kan? In terms of the social community at that workplace. So this is the thing when talk about collaboration with the client. So I like this model, Canadian model of client-centered enablement, CMCE. This one I like it because we as an OT, we not only coaching them, we should educate them, we should engage them, we should specialize, we should design, we should coordinate and collaborate, and we can become advocate. We need to adapt. So this element, as an OT, as a professional, you must have element of this client model of client-centered environment. Is we not only become a coach, but also we become a consultant. We also become people who are specialized in work in our area. We can educate the public. So this element should be inculcated to the OT as a profession. So this is the summary what we have discussed in terms of evaluations, in terms of intervention and the outcomes. I've done my talk in terms of what are OT in adult and psychiatric mental health, in terms of promotion, prevention, rehabilitation, and psychosocial rehabilitation. So, as an OT, whatever we do, we must document or the individualized care plan based on the findings of the assessment. We have to document whatever our finding. We must put in written so that other therapists or you want to relook back, you want to do a research, retrospective research, so we can do that. So as an OT, we must document individualized care plan based on the finding of the assessment. So we need to take into consideration the functional level of clients, their severity of disability, their cultural, social, dia punya religious norms, and duration of session. The age of client also we need to consider their role and routine and their needs and priorities. This is the thing that we need to consider, especially dia punya cultural, social, and religions dia. So our client ni have different background of religion. Ada yang Sikh, ada yang Indian, Chinese, Buddhist. So we have to consider all that. So you have to plan your goal. So your goal and care parts should be discussed with the clients, the family members, and also other professionals in the team. So you should design your goal. It should be short-term goals and also long-term goals. So you need to identify the problem, then statement of measurable goals, both short and long term, selection of intervention taking into consideration the plans of other professionals, a schedule for the implementation of the program, evaluation schedule, tentative discharge plan. This is the thing. When we planning, we need to identify the problem and we need to state the goals, short term and long term. So short term and long term, you must state 3 weeks ke, 4 weeks ke, 1 day ke, long term, months ke. So you must state that. And then you need to consider other plans, social worker plan, clinical psychologist punya plan, we have to consider. And then you have to schedule the program that we design, and then evaluate the schedule. And then at the end, we must have discharge plan. Discharge plan, very important. So whenever you receive patient, at the end tu mesti discharge. Janganlah simpan dia semata-mata untuk dapat statistik. Ada terapis di department mana saya tak tahu yang dia sengaja simpan pesakit sebab dia nak, walaupun pesakit itu dah independent, able to work outside, able to discharge, tapi dia tak discharge semata-mata kerana dia nak statistik dia banyak patient ada sesi rawatan dan sebagainya. No, it's wrong. It's totally wrong. We need to have tentative discharge plan. Apa plan bila balik tu macam mana? Dia nak duduk dengan keluarga dia, dia nak independently by himself or herself, they have to go back to the punya spouse. This is very important. When we treat patient, jangan lupa discharge plan dia. Jangan simpan dia. So in terms of evaluation, you must remember, you need to reevaluate the progress of the client. So depend on the occupational performance tu, depend on the form. You must adalah time untuk buat reassessment, reevaluate. Then if you found that your intervention not according to your plan, so you need to reassess balik, realign balik you punya care plan. This is the when talk about modality, about the intervention. Contoh-contoh macam intervention ni, contoh problem solving skill. So your goal is to increase problem solving skill to the patient. So the possible modality that you can do, assertive training, assertiveness training. This is involved of you want to make your client assertive so that when there is a problem, you are able to independently solve the problem. Dia ada skill untuk solve the problem. Creativity. If your client have an issue of creativity, you want to improve dia punya creativity. So you using expressive modality For example, art, creative writing, interpersonal flexibility. For example, dia ada problem of relationship, dia rigid, dia tak socialize, dia ada withdrawal syndrome, dia ada problem of communication. So you want to improve dia punya interpersonal flexibility. So you use this modality, which is group discussion and activities and environmental modification. If there is suicide prevention, what condition yang ada suicidal thought? Any one of you?
Depression.
Yeah.
Depression.
Depression. Lagi apa?
Schizo.
Schizophrenia yang severe stage, kan? Lagi?
Yes.
Lagi? Apa kes yang ada suicidal thought? Anyone? Dah belajar condition kan? Apa ada lagi? Yang right now, contoh macam right now you ada dengar tak berita berita pilot terjun tingkat 14 ke apa? Because dia dah lost dia punya livelihood, hutang banyak, komitmen banyak, tak boleh bayar hutang, alung kejar, itu semua ada suicidal thought. So whenever people yang ada suicidal thought ni, you need to prevent them. What are the modalities? Expressive modalities, support group intervention, participant in leisure activity. Participant in leisure activity also can help reduce dia punya suicidal thought. Expression modalities, for example, gunakan art therapy, express dia punya thought tu. Dia punya thought keadaan sekarang. So from that you discuss and you bagi moral support, you bagi encouragement. So they are the problem of relationship with the family. So what you going to do? You have group activities, you have discussion group, you ada assertive training, you ada role play. Jadi pun boleh buat role play, drama. Macam mana bila drama, contoh drama keluarga. So macam mana dia nak express bila dia bercakap dengan parent dan sebagainya. So you can do that. Yang ada masalah behavior problem, probably you can do sensory integration, and then behavior program, appropriate reinforcement and extinction. Dia ada reinforcement banyak. Kalau kes dekat psikiatri ni banyak behavior problem. Ada yang suka jenis kencing di tiang pathway tu, kat ward tu, dia kencing dekat situ. Behavior problem. Dia suka mencarut, it's a behavior problem. Dia suka meleset, dia suka pegang perempuan, also behavior problem. Apa lagi? Dia suka cakap sarkastik, menyindir, also behavior. Dia suka ada temper tantrum, also behavior problem. So banyak. Dia senang sensitif, so depan cepat marah, also behavior problem. banyak kes dekat psychiatric, issue of behavioral problem. Okay, one of the the thing that we do in a psychiatric setting is vocational transition. Some of them, when they punya occupational history, for example, dia policeman, katakan policeman, dia ada depression. So in order to return them to work, to return patient to work, is quite difficult because police task tu, as a police, you punya work demand dia tu, in term of physical, in term of processing of skill processing, in term your punya communication and interaction, is going to be tough for him to return to work because dia dah dapat schizophrenia dan sebagainya. So you kena ada vocational transition. You need to train them in different punya vocational because dia punya job demand tu tak sesuai untuk dia kembali due to dia punya condition, disorder. So you have to do vocational transition. So for that, you need to have task analysis of work that's suitable for the client. And then dia punya interest also you need to consider. And then you need to consider the skill, work task. What are the tasks, what are the component of work skill that need to be practiced. So they call it vocational transition. And then management of time. So you need train some of them. They have problem of managing their time. So you need to educate. You need to make them practice timing. Activity balance and satisfaction. This is the thing that we can do. Interest assessment, group of individual discussion of interest, practice of new activities. Leisure interest, interest assessment, experimentation with activities, discussion of resource, self-esteem. Some of your patient ada masalah self-esteem and also self-efficacy. So you need to analyze, and then some of the activities above can improve self-esteem and self-efficacy. General health, exercise, hobbies, social interaction, develop interest to them. So, in psychosocial rehabilitation, we need to understand theory, approach, model, and frame of reference in psychosocial rehab. So what are different between theory, frame of reference, and model? Anyone? Diana? Mana Diana? So what are the different, Diana? Theory, frame of reference, dengan model. Diana ni post diploma ke matrik? Hello?
Ya, doktor.
What are the what are the difference between theory, model, and frame of reference? Boleh tak ceritakan?
Kalau model tu dia macam payung apa kita punya guidance. Kalau intervention tu kita memerlukan model untuk kita punya guide lah kita nak buat apa kan. Kalau FOR ni more tu kita punya approach. Kita ada banyak FOR tapi apa yang paling sesuai dengan intervention tu.
Ya.
Betul tak doktor?
Tak apa, kita tanya orang lain dulu. Husna?
Alright.
Husna? Apa dia? What are different between theory, model, and frame of reference? Husna?
Ya.
Saya tak nak tunjuk.
Teori tu teori tu yang satu kefahaman pasal, contohnya kalau satu intervention tu, kalau ada teori, so kefahaman kita terhadap satu intervention tu. Kalau FOR tu kita kena FOR tu kita punya guidance untuk kita buat treatment.
Jadi buat treatment Okey.
Ha.
Okey, Narain?
Kalau
Narain pula. Narain? What is the difference between theory, model, and frame of reference? Ain? Narain Nadira? Jangan lagi pula. Narain? Apa dia? Yang lain siapa yang boleh jawab ni? Adib, Nur Adib? Nur Adib boleh jawab? Boleh explain tak? Senyap je Nur Adib. Okay. When talk about theory is a idea, idea ataupun assumption. Dia ada idea. Teori ni is about your idea, ataupun assumption. Teori benda theoretical, teori katakan. Contohnya, human occupation. Human occupation is a theory actually. It's a theory, idea ataupun assumption. For example, human occupation theory. So, human occupation theory ni dia punya idea bila people injured, dia ada when people injured or dapat penyakit dan sebagainya, dia ada isu, dia ada akan efek dia punya performance skill, dia punya volition, habituation, kan, dengan dia punya performance skill. Ini teori. So talking about model is that people accept it. People accept teori ni to be practiced. Dia become model of human occupation. That's why kalau teori itu, contoh Sarah boleh come up with teori. Ni idea Sarah. Tapi bila idea Sarah ni telah diterima oleh semua orang, masyarakat setempat ataupun profession tu, dia become a model of practice. So this is the difference between theory and model. So when talk about frame of reference, is an individual personal notion of reality, their culture, social and psychological bias, their values and beliefs, and how these factors influence the practice of OT. This talking about frame of reference. So, sertakan frames of reference of something, kita tengok dari segi dia punya reality, dia punya culture, dia punya social. So approach is way and means of putting theory into practice. Approach is a way cara kita nak buat teori itu into practice. Tapi kalau model ni teori tersebut telah dipersetujui oleh setengah kelompok tu untuk dipraktiskan. Dia panggil model human occupation. Canadian performance model, COPM. Canadian occupational performance model, COPM. Model of human occupation, MOHO. Teorinya ialah teori, dia ada teori dia, dan this theory being accepted oleh OT Amerika, oleh OT Kanada. So, kalau kita bagus orang yang filosofi, mungkin in future you come out with theory, another theory for Malaysian punya OT untuk practice. So frame of reference lebih kepada their beliefs, their values, this one. So remember that when talk about theory, approach, model and frame of reference in psychosocial rehab. So when talk about frame of reference, contoh rehabilitatif, dia punya fokus dia lebih kepada improve function in the activities of everyday living. This is the thing that in terms of rehabilitative, we want to improve the punya activities of everyday life. Activity of everyday life. The punya frame of reference is rehabilitative. Psychodynamic frame of reference is that resolving unconscious conflict and strengthening ego defense mechanism. So they call it psychodynamic. Behavioral is a learning skill to support appropriate behavior. So kalau you want to improve psychiatric patient behavior, dia ada behavior contoh dia cepat marah. Dia cepat marah, tak tentu pasal, senang sensitif. So you want to improve dia punya appropriate behavior by teaching them. You come out with skill how to cope with scarcity, cope untuk dia ada skill untuk improve dia punya behavior. So behavior frame of reference. So occupational behavior, learning skill to support a balanced range of activities and occupation. They call it occupational behavior. Learning skill to support a balanced range of activities and occupation. So occupational behavior frame of reference. You ajar dia skill-skill macam mana nak balance pelbagai aktiviti dan juga occupation. Contoh, you nak balancekan bila bekerja, balik kerja, ada leisure, spend time bersama family. So they call it occupational behavior. Human development to facilitate normal development to an age appropriate level. So kalau human development frame of reference, for example, kanak-kanak tu dia punya development sebelum dia dia boleh duduk, dia kena merangkak dulu, dia kena buat turning kan, supine, pronation. You want to improve from from lying to sitting. You improve the punya skill from lying to sitting. This is human development. Human development frame of reference. This one, another one, cognitive behavioral. So identify and modify negative cognition, affecting mood and behavior. So you want to teach them, to educate them or train them to identify negative cognition. Contoh, kalau you nak bertanding sukan, you tak boleh ada negative thinking. Bila you ada negative thinking, so you punya mood, you punya semangat untuk menang tu dah hilang. You mesti improve, you mesti ada skill positive thinking untuk improve you punya mood dan semangat you untuk bertanding. Ini kalau dah ada negative cognition, saya belum berlawan bertanding, you dah fikir negatif. Dia kuat, dia tak boleh apa-apa, nak lawan pun tak boleh. Nak bertanding lawan dia tak boleh, dia ni kuat, dia pandai, badan besar. So you dah ada negatif. So you want to improve dia punya, you want to improve, you want to train, to modify dia punya negative cognition. They call it cognitive behavioral. Cognitive disability, assessing level of cognitive function and providing tasks appropriate to that level. So you buat this called cognitive disability frame of reference. For example, like people yang ada traumatic injury. So dia punya cognitive function, dia boleh ingat nombor, campur tolak 2 angka saja. So you assess, this dia punya cognitive level function. So you want to prepare task yang appropriate dengan dia punya level cognitive function. Dia boleh campur tolak 2 angka je. Lebih daripada tu tak boleh. So you want to provide task, kerja yang sesuai dengan dia punya level of cognitive. They call it cognitive disability frame of reference. Okay. So ada soalan tentang frame of reference. So, for example, you...
Doktor,
Yeah.
boleh tak terangkan sikit lagi pasal yang psychodynamic? Macam mana unconscious conflict tu macam mana?
Okay, apa dia? Sorry, soal lagi? Siapa nak tanya tadi? Saya tak berapa dengar tadi.
Hello doktor, dengar tak?
Okay, dengar. Okay.
Okay, boleh tak terangkan lebih lagi pasal psychodynamic tu?
Psychodynamic.
Macam unconscious conflict tu macam mana? Psychodynamic.
Okay, psychodynamic is involve psychology. Psychology by improve dia punya psychology. Dynamic, improve dia punya psychology dynamically. Maksudnya you strengthen dia punya psychology dia. So for example, seorang yang pasif. Pasif ni, contoh dia seorang yang pasif. Especially contoh masalah personality withdrawal, atau personality dependent personality. Slow sikit, Mel. Dependent personality. So dependent personality ni, dia ni orang yang pasif, kan? Dia tak ada ego. Dia akan ikut apa yang you nak. Dia ikut dia. Kalau tak ada apa, kalau tak ada okey, dia seorang yang pasif, dia tak ada ego, dia orang yang tak ada ego, tak ada stand, kan? Tak ada stand. Dia ni jenis yang okey, apa yang nak buat okey. So seorang pasif. Orang pasif yang contoh personality dependent personality. Dependent personality ialah seorang yang ada masalah ego. Dia tak ada, dia seorang yang pasif, dia bukan seorang yang assertive. So macam mana you nak bagi dia, nak improve dia punya personality. So you kena buat psychodynamic. Psychodynamic ni lebih kepada individual approach. You psycho dia punya apa ni, dia punya ego, dia punya insight dia, supaya dia seorang yang ada stand diri, dia tak dependent pada orang lain. So you want to resolve dia punya unconscious conflict. Kadang ini I taking about negative lah, yang pasifnya. When top people yang ada ego, lain pula cara dia. Kadang ada orang yang really ada ego. So macam mana you nak reduce dia punya ego? So you kena buat individual therapy, they call it psychodynamic therapy, psychotherapy. Dalam psychotherapy itu ada involve individual discussion, individual brainstorming, individual argument. Nak bagi dia realize, nak bagi dia change dia punya ego, nak reducekan dia. So they call it involve psychology of the person. And they call it psychodynamic. And in terms of psychodynamic ni, not everyone can do it. Some of dia ada certification, dia ada further study. They call it psychotherapy. Psychotherapy lebih kepada psychodynamic frame of reference, melibatkan psikologi seseorang. Ya. Ada soalan lain? Yang lain ada soalan, semua faham So, whenever you design your punya intervention, you punya activity, you must have this frame of reference. Whether your activity more on rehabilitative ataupun yang melibatkan behavioral atau occupational behavior ataupun qualitative behavioral atau quantitative disability. So, your intervention should be designed based on this frame of reference. And then you want to know more, you read Jennifer Crick punya buku. Dia punya book, dia punya writing tu ada explain lagi tentang ni. This is the SOP, Standard Operation Practice by OT at KKM. So OT KKM ni, dia punya level of intervention of adult psychiatry, dia ada dia punya level. But for me, it's not really academic and client-centered punya approach, because this design lebih kepada stereotype punya design. Contoh dia cakap level 1, diagnosing phase, individual group, to get more information from patient, family and carer, to know the positive and negative symptom, to know about drug reaction. So dia punya intervention, physical activity, self-awareness activity, psycho-education, indoor and outdoor activities, expressive activities. So dia jadi macam dia dah sediakan program. Dia tak really analyse yang kita dah OT intervention process domain tu. Dia tak go through that. So it's really not academic, not really client-centered approach, and really for me is non-academic punya approach lah kalau dia buat levelnya. Dia ada level 1, level 2, to draw a care plan based on the level 1 information. Dia ada intervention, IDL, ADL, social skill, assertive activity, cognitive therapy, duration buat 1-2 weeks. Tapi really not client-centered. Ada level 3, pre-discharge space. Individual group to empower and get ready to be involved in work vocational rehab. Vocational 3 stages, pre-vocational, vocational bridging program, intervention work, vocational rehab, pre-vocational explore stage, explore skill and potential, prepare to gain good skill, communicate with family members, support from family, vocational stage, all these things. And then duration dia 1 to 3 weeks. This one another punya program. Level 4. Level 4 discharge in community for job placement. Tapi this is the long term punya. Level 4 long term. Depend on the performance of the client, dia punya duration. So dia dah structured macam ni. Dia dah saja level 1, level 2, level 3. If you experience practice at OT KKM, dia punya level of intervention and psychiatry based on not based on the occupational description and also other context, for example cultural dan sebagainya, lebih kepada stereotype punya non-academic punya intervention. This I just want to highlight you all because when you go to practice, different pula approach dia. So you should be aware of this thing. So ada soalan tentang ni? Semua okey?
Okey, doktor.
Ada soalan nak tanya?
Tak ada, doktor.
Kenapa tanyalah kenapa berbeza pula antara KKM ni practitioner dengan
Saya nak tanya.
okay.
Kalau untuk discharge tu kan sebenarnya itu pengesahan daripada doktor kan, macam doktor yang boleh dischargekan patient tu. Betul tak?
Okay, lagi.
Okay. Jadinya kita punya intervention tu kena based on macam based on macam mana nak cakap, macam okay, saya cerita saya punya praktikal hari tu. Saya patient tu dia tiba-tiba je discharge. Tiba-tiba doktor boleh dischargekan dia. Macam tu lah.
Have you talked to psychiatrist?
Saya dulu tengok SOP macam mana? SOP daripada doktor je lah. Pagi tu saya cakap tiba-tiba patient dah discharge. So saya rasa macam saya tak sempat habiskan intervention saya dengan dia. Macam tu.
Yes. Okay, good discussion Yasmin. Actually it depends on the OT and also the doctor punya approach lah, the way of you treat patient kan. Dua-dua sekali lah, OT dengan doktor. Some when I work at if you know contoh dia work as a team. Problem sekarang ni ada setengah tempat ni they not working together as a team. So doktor, OT, refer, nak discharge, tak ada meeting, tak ada discussion. It means that there is no collaboration with team collaboration. This is the problem. Actually, whenever they plan to whenever they see the patient, they should discuss together with the OT and other profession They work as a team. So whenever planning for the patient, they discuss together with OT, and then whatever they want to decide, they should have discuss, then get feedback from OT, from social worker, and that involved with the management of the patient. From my experience, I got no issue of that because the doctors, nurse, and we work together. When patient come, when they want to refer, together with the doctors, discuss what are the plan, what I want to do with the patient. So what I want to improve with the patient, what the outcome I want with the patient, and then we agree. And then whenever they want to discharge, they will seek information to us. That's the way it should be lah. Work together, OT, doctor, and then some of the OT need to explain to the doctor and get to know get to know the doctor. Kadang doktor pun tak kenal OT. Siapa OT ni? So very important. When we work at the psychiatry, we need to collaborate, work together with the doctor, with the social worker, and work as a team. Work as a team. Betul tak? Siapa yang tanya tadi?
Betul.
Yasmin Apa? Yasmin?
Saya.
Yasmin ada jumpa doktor yang refer tu tak?
Jumpa setakat meeting je lah, grand walk round.
Grand walk round, and then ada jumpa personal dan sakit ni.
Lepas tu
tak ada kan
esoknya tahu-tahu patient dah tak ada dah.
Bila patient discharge, Min ada bincang tak? Yasmin ada bincang dengan doktor tu. Kenapa doktor discharge dia patient tu?
Tak ada.
Tak ada kan? You should know, some of the doctor ada dia punya isu ataupun dia punya polisi. Katakan patient tu short stay, dia tak boleh tunggu lama sebab bed makin kurang, ataupun request from the family ke, from the patient ke, we don't know. So whatever, discuss with the doctor. Why, sir, doctor, can you tell me why you discharge the patient? I still on, we have a plan to do with the patient, kan? Kalau you discuss, and then you should provide evidence shows that the patient need to go through this intervention first before discharge. Then doktor akan pandang tinggi kat you. Tak suka hati buat sebab dia rasa you commit with your work. You ada commitment dengan you punya work, and then you really work for your patient. Kalau ada tu, insyaAllah tak ada isu. Discharge sebelum you buat intervention dan sebagainya. Yasmin?
Okay, doktor. Thank you.
Think positively. And next, kalau you ada peluang posting kat psychiatry ataupun you bekerja kat psychiatry, open your mind and build a good relationship with the doctor. Bila you dah ada good relationship macam I do dekat rehab center ni, patient nak discharge pun mesti melalui saya. Tanya saya dulu baru boleh discharge. What Sulaiman going to do with the patient? Ask Sulaiman first before discharge. Dia macam itu sekali. Sebab dia respect kita, sebab kita commit dengan kerja kita, and we know A to Z about our patient. Okay, Yasmin? Alright.
Okay.
Thank you, Yasmin. Good discussion. And it's not, we have to open our mind when working in this area. So ada soalan lain? Bagus, Yasmin tanya soalan. So,
Doktor.
Okay.
Doktor.
Siapa ni? Nama sebut.
Saya Diana.
Okey, Diana.
Diana.
Okey, Diana. Okey.
Okey, macam soalan Yasmin tu kan. Saya tak tahulah, mungkin environment hospital tu lain-lain. Tapi saya rasa mungkin sebab student ni kan macam ada jurang antara doktor dengan OT dekat hospital tu kan. So macam mungkin apa yang lagi-lagi student kita praktikal. So macam dia loose kat situ. Macam kita tak ada kuasa sangat. So macam mana doktor?
Ini kuasa diraja kurang lah.
Kuasa tu.
That's why you not only have to work with the medical doctor, but also have to work together with the therapist yang in charge, kan? Yang in charge dekat hospital. And CI also. You masa training tu ada CI Diana?
Ada doktor.
CI also have to work together with the therapist yang in charge tu. Kalau at the beginning, CI discuss with the OT, therapist OT, and then discuss the doctor. Would you mind doctor, my student still doing intervention with the patient. So this patient still in the stage of doing this thing, intervention of this thing. Evidence shows that. Then doktor akan respect kita. Jangan diam je macam orang asing kan. Doktor dah discharge. Discharge dah. Patut pergilah bincang dengan doktor tu. CI, OT yang bekerja kat situ dengan doktor kat situ. Doktor, kalau kita able to discuss case tu, kita ada evidence, tunjukkan komitmen, they are very happy. They are very happy because he think he's the one only knows about the patient. But no, every health profession, especially OT, we knows about our patient punya condition. So next time kalau ada opportunity, kalau you ada untuk macam you practical, CI you tak proaktif, tak ada participation, tak nak bercakap dengan doktor, tak nak communicate dengan OT, you tell us so we can advise, we can come over there to discuss with the team. Okay, Diana?
Okay, doktor.
Okay, okay, kalau ada yang lain nak tanya? Ada? Kalau tak ada, kita teruskan. So, level of evidence. So, whatever we design our intervention, we must appraise our evidence. Appraise evidence, we have to read the article. That's why dalam lab group activity, whatever you design, you must appraise ada evidence tak ni. So, as you all know, we only exist 100 years. This is 100 years of our existence. So, level of evidence, American OT Association, AOTA, dia ada describe level of evidence. So whenever we want to design intervention, we must recognize, we must appraise apa evidence tu, what evidence level 1 ke level 2. So American OT Association have put in their group kan, and talk about level 1. So level 1 involves systematic reviews, meta-analysis, RCT. So this is level 1 punya evidence. So level 2 lebih kepada involve two groups, different of two groups, non-randomized study. For example, like cohort study. Cohort study tahu tak? Cohort study dia buat jangka panjang. dia buat 2 tahun, 4 tahun, setahun. Ni cohort study. Case control lebih kepada case. Dia buat dalam 10 case, 12 case kan. Tu level 2. Level 3 lebih kepada one group and non-randomized, before and after, pre-test and post-test. Untuk pre-test, you buat intervention sebelum dan selepas, apa dia punya different, dia punya finding. Level 4 lebih kepada descriptive studies that include analysis of outcome. Can be single subject, design, it can be case series. Ada study, kadang-kadang OT dia buat case study, single case study. Dia ceritakan tentang apa outcome, hasil dia punya kajian tu. Also we can accept, but this is level 4. Level 5, case report and expert opinion that include narrative literature, review and consensus statement. So level 5. So kalau you tengok, kalau you buat design intervention, you kepirkan sekali dia punya level evidence based on American OT Association. Level 1 ke, level 2, level 3, level 4, level 5. Kalau medical, they are very strict. For example, like vaccine tu kan, vaccine COVID-19. They using RCT, randomized control trial. That's why vaksin tu ambil masa. Dia very strict because dia tak nak jeopardizkan human being punya nyawa. So that's why nak dapat vaksin tu 2 years baru dapat, sebab dia ada stages dia. Stage 1, stage 2, stage 3. Apa bilangan numbers pun dalam group tu dia ada bilangan numbers dia. So but our level of evidence, we accept level 1, but we know lah, this level 4, dia involve single subject, this level 3, menyebabkan yang buat one group only, tapi kita buat pre and post, pre-test and post-test. Level 2, jangka lama, study lama, cohort study. Kalau level 1 melibatkan RCT. Nanti you dah belajar research methodology kan? Dah? Dah semua?
Belum.
Belum lagi, tak apa. Bacalah sikit artikel, apa Google kan apa tu RCT dan sebagainya. Okey, kalau ikut psychiatry, SOP, dia guna ikut Catalonian agency from Spain. The level of evidence scale ni ada level 1, 2, 3, 4, 5, 6, 7, 8, 9. Kalau good ni, level 1 and 2. Apa dia? Meta-analysis systematic review. Large sample RCT. Ni kalau vaksin tu, dia nak buat level 2. Large sample RCT. Kalau good to fair, 3 and 4, small sample. Non-randomized control prospective trial. Dia buat RCT tapi dia tak buat RCT tapi dia buat comparison juga. Kalau fair, 5, 6, non-randomized dan juga cohort study. Poor ni yang buat single study, yang buat non-control clinical series, yang expert committee, ni poor lah. Level 7, 8, 9. Kalau evidence dia 7, 8, 9, according to CASTAR, C-A-S-T-A-R, Spain, ni dia lah. Poor ni tak bagus lah. Biasa ni dia akan ambil yang level 1 to 4. Barulah dia gunakan dia punya ubat. Ini guna Scottish punya Scottish dia guna grade A, B, C. Grade A, B, C. A apa dia? A melibatkan meta-analysis, systematic review, or RCT. Ni. B, evidence from well-conducted clinical trial to the target population, demonstrating overall consistency. Evidence extrapolated from meta-analysis, systematic review, or RCT. C, evidence from expert committee, report, opinion. C. So, doktor ni akan ambil level grade tu sama ada A, B, C. Kalau ada intervention yang level grade dia A, so dia akan ambil yang grade A lah. Okey. So kita dah hampir 2 jam tentang introduction ni. So lecture yang pertama saya dah habis. Ada soalan yang nak tanya? Lecture yang week kedua. Saya belum uploadkan lagi dalam folder. Dah ada ke belum? Belum ada lagi kan? Saya belum upload.
Belum.
Kemudian saya ada artikel-artikel yang saya nak you baca. Nanti saya uploadkan. So, baca artikel tersebut. So, next week, masa yang sama, pukul 2.30, saya akan randomly choose. Contoh macam Alia Najiha. What are these article about, Alia? So, Alia kena explain in front of others tentang that article. Yeah. Ada soalan tentang topik ni? Semua tak nak tunjuk muka.
Doktor,
Ya. Okey,
saya
Hazika.
nak tanya pasal kalau psychosocial frame of reference, dia sesuai tak juga untuk patient psychiatric?
Psychosocial.
Dia sebenarnya in term of apa? Boleh tak terangkan sikit?
Okey, psychosocial ni is trend sekarang. Psychosocial ni lebih kepada involve community. They call it psychosocial rehab. Involve of community, involve of the environment they are living. Masyarakat setempat tu. They call it psychosocial rehab. Psychosocial rehab ni pendekatan approach. Dulu kita banyak institution. Dulu kita masyarakat, dia punya trend, dia punya approach untuk melawat psychiatric patient ni lebih kepada institution. Maksud di institute. Itu sebab banyak hospital Pemai. Ada ditemukan hospital Pemai, hospital Tanjung Rambutan. Sekarang ni bila rawatan makin berkesan, bila rawatan makin berkesan, jadi approach dia sekarang ni berbeza. Dan dia ada buat study mengatakan kalau melibatkan psychosocial rehab, maksudnya melibatkan community, melibatkan family, melibatkan jawatankuasa setempat, dia punya dia punya outcome tu lebih baik. That's why they call it psychosocial rehab. Macam dekat Tanjung Rambutan, dekat pun dia ada psychosocial rehab punya unit. Dia di luar daripada hospital. Dia duduk di masyarakat setempat. Tempat dia lah. So patient ni datang ke situ. Dia ada program, ada terapis, dia ada program, kemudian program tu melibatkan masyarakat setempat. Kalau dia buat work job placement, so dia ada proses lah. Psychosocial rehab ni, kemudian mungkin dia ada daycare center, buat permulaan. Patient akan datang every day sampai daripada pagi sampai tengah hari, kemudian dia tingkatkan lagi daripada pagi sampai petang. From there, dia improve dia punya social skill, interpersonal skill, dia punya work behavior, dia punya performance skill, IADL skill. Lepas tu dia prepare for work, job placement. From there, they do job coaching. Job coaching, for example, kita ni kalau nak bekerja, kita kena buat resume, betul tak? Kita kena pergi interview. So dia coach the patient tu untuk go through this thing. Macam mana nak interview, macam mana nak sediakan resume, macam mana nak dari segi penampilan, appearance, dari segi percakapan. Kemudian dari segi macam mana nak buat problem solving. Kemudian terapis di community tersebut akan negotiate dengan employer. So dia akan tempatkan di employer, di industri. Bila di industri nanti dia akan follow up. Dia akan buat follow up. OT itu akan buat follow up. So pendekatan dia akan mungkin dia interview patient, dia tanya apa dari segi environment, apa yang interfere dengan dia punya performance. Ada tak environment tu bagi support kat dia, apa interference ataupun restriction untuk dia perform kerja kat situ. Kemudian dia OT ni bila dah interview, dia tengok this is the problem, this is the restriction yang hindering dia perform untuk performance dia kat tempat kerja. So dia akan consult, dia akan advise employer tempat kerja. So more OT in community, more in they call it psychosocial rehab. Yeah. Good question. Ada lagi nak tanya? Semua okey? Alin?
Okey.
Tunjuklah muka. Semua tak nak tunjuk muka Alright semua? Tak ada soalan? Okey, nanti saya uploadkan lecture note saya. And then saya akan uploadkan artikel yang you kena baca. And then next week you kena present bukan dalam guna slide lah. Tak payah guna slide. Just informal communication dalam Zoom ni. Semua orang boleh dengar. Sebab apa I nak develop you all to be assertive dalam discussion, assertive dalam memberi komen, input. Kita discuss academically discussion. Kalau tak ada apa-apa, saya endkan kita punya sesi week 2 lecture. And I hope you all stay safe, stay home, and kita jumpa next week, ya. Okay. Bye semua. Kita jumpa lagi.
Thank you, sir.
Thank you, doktor.
Thank you, doktor.
Doktor.
Thank you, doktor.